So, Mr. Smith, we are going to put this chest tube in.
When your patient needs a chest tube, prepare him by explaining the procedure and providing reassurance, making sure that the physician has obtained informed consent, and administering an analgesic or a sedative as prescribed. Also, prepare the equipment, including the closed chest drainage system. With the drainage system assembled, prepare a sterile field for chest tube insertion. For an uncomplicated pneumothorax, expect the physician to use a 14 French or smaller chest tube. To drain thick fluid or remove fluid or air rapidly, expect the physician to use a larger diameter catheter.
Okay, and lean over this table.
Help the patient into an appropriate position. If he can tolerate sitting upright, have him lean over a bedside table to accommodate a tube in the 4th or 5th intercostal space, usually lateral to the nipple line. Otherwise, help him into the lateral supine position with the affected side up.
Mr. Smith, let me see your ID badge.
Before the procedure begins, be sure to follow Joint Commission guidelines for preventing wrong site, wrong procedure, and wrong person surgery. Expect the physician to apply antiseptic to the insertion site. Then expect her to inject a local anesthetic, such as lidocaine, to numb the area. While the physician inserts the chest tube, reassure the patient and assess his pain level. Administer another dose of analgesic if indicated and prescribed.
Yep, there
It's
we
in,
go.
okay?
After the chest tube is in place, help the physician connect it to the drainage tube on the closed chest drainage system, keeping the connector sterile. As ordered, set up wet suction, dry suction, or gravity drainage. The type used depends on how much air must be removed and how quickly the pneumothorax must be resolved.
Try to relax and let the chest tube do its work.
After the physician sutures the chest tube in place, apply a dressing to the insertion site. If ordered, use petrolatum gauze to create an airtight seal around the tube. Then apply a dressing, such as fenestrated or split gauze and 4x4 occlusive gauze, and tape the entire surface of the dressing. Secure all tube connections with tape or nylon bands to help prevent an air leak. As ordered, arrange for a chest X-ray to confirm tube placement in the patient's pleural space. After chest tube insertion, perform follow-up care. Initially, check your patient's vital signs every hour. Watch for hypotension, tachycardia, and tachypnea, which can signal a tension pneumothorax. Auscultate your patient's lungs at least once every hour initially. Expect clear breath sounds to extend to the periphery of the lungs, a sign of reinflation. If the lung sounds remain diminished on the affected side, the chest tube may not be resolving the pneumothorax and may need adjustment, replacement, or increased suction.
Okay, good.
Remember to check the patient's oxygen saturation every 2 to 4 hours or as ordered. Report a level that's below 95%, a sign of hypoxemia caused by impaired ventilation. Remind the patient to cough and deep breathe at least every 2 hours. Doing so can help reinflate the lung and ease his breathing.
0 is no pain at all.
Regularly ask him about incision pain and pain with deep breathing, and administer analgesics as prescribed.
Just double check. Good.
Check the chest tube dressings frequently to detect blood or other drainage. Change the dressings according to hospital policy. Also, palpate around the insertion site to detect subcutaneous emphysema. To facilitate chest drainage, reposition your patient at least every 2 hours and maintain a high Fowler's or semi-Fowler's position if tolerated. Check the character and volume of the chest drainage once every hour or more often. Near the drainage chamber, mark the date, time, and fluid level according to hospital policy.